Welcome to the Longevity Optimization Podcast, where we discuss longevity, optimal health, nutrition, peak performance, cognitive excellence, and so much more. Dr. Robbins, it is such a pleasure to have you here with me today.
Thank you. Such a pleasure to be here. I love everything you're doing and excited to be here. Thanks, Kayla.
Thank you. Of course. I mean, today we're going to be talking about such an important topic, female health. Mm-hmm. And before we jump into it, you have a background in OB/GYN medicine, and of course, you're a medical doctor. Can you talk a little bit about your background and what made you start your own practice and leave kind of the traditional medicine setting?
Yes, absolutely. So I'm board certified in obstetrics and gynecology, and I was working at a really large practice. And a couple things sort of happened simultaneously. One was I kept seeing this recurrent pattern emerge of women in their late 30s or early 40s coming to me saying, you know, I'm not sleeping, or I don't feel great, or I can't lose this weight, or just like a lot of stuff that I didn't feel we were helping really in the traditional model. And I also, ironically enough, was having kids during this time and found out that I was extremely insulin resistant. I had gestational diabetes requiring insulin, which kind of is a very humbling experience. I couldn't control my weight gain, didn't feel great, felt awful in my pregnancies. And, you know, when I was done having kids, had a really hard time losing the weight. And so I kind of got really interested in prevention and sort of understanding this better, because I realized that what we tell patients is so overly simplified. And I was like, how, if I can't lose this weight and I can't sort of understand what's happening in hormones in pregnancy, how can I help my patients? And so I, through just being my own experience personally, being very insulin resistant and wanting to better understand insulin and prediabetes and metabolic syndrome, decided to do an extra training for a year in lifestyle medicine, because I wanted just to have a better foundation of the evidence behind how to live a healthy lifestyle. And so that happened at the same time when I felt like we were letting women, after having kids, sort of just be on their own without giving them much guidance. And I thought, I really want to create a practice where that's what we do. We take care of women. We give them guidelines for prevention. We help them manage like supplementations. We, you know, we test for bone densities earlier than 65 years old. We, help them with sleep and energy and libido and all the things that we tend to honestly not prioritize. And as I studied this, I just realized, wow, like this is such an important time in a woman's life in their late 30s and 40s and 50s, when you still have the opportunity to prevent disease. It becomes much harder in your 60s to reverse disease, you know, at that point. And so I felt like I just felt like we weren't doing a great job of helping women kind of thrive and know what to do in their 40s. We put so much priority and emphasis in fertility and reproductive years in obstetrics, which is, of course, so important, but it's also important after that as well. So my clinic is sort of primarily focused on women I'd say the majority of my patients are in their late 30s or early 40s.
I love that. I think it's so important. And obviously, thank you for focusing on women, because we all need that.
Yeah.
You mentioned that in your standard practice, when you were working at like a big clinic, that you kept seeing women kind of come in for the same thing over and over, because most women at this point probably are seeing more of a standard or traditional practice. What did that mean to you? So you were seeing people come in over and over and maybe not having symptom relief. Why do you think that was? Was it because it wasn't built for actual optimization, or
yes, so a couple of reasons. One is I do think it's very, and one of the pieces of advice I give to women is, if you feel that because traditional OB/GYNs do both obstetrics and gynecology, and the reality is obstetrics and pregnancy takes up 90% of that practice's bandwidth. And so if you're not getting the answers, you need to try to switch to someone who just does gynecology, because women, when they're not having kids, have a whole different set of issues. And it's a lot for the same doctor to be excellent at both. That's the reality. In my opinion, obstetrics and gynecology should be separate specializations because there's such different needs. But anyway, so part of it was that, in the traditional model, we just don't have enough time with patients. And this is a problem because of insurance companies just not reimbursing basic things for women's health. And so the visits, doctors are sort of forced to see 30 to 35 patients a day because reimbursements are getting less and less. And these are complex issues that really can't be addressed in a 15-minute visit or even in your annual when you're like sitting in stirrups and trying to get your pap smear. Like, these are issues that take up time that we really have to get into the details with. And the other piece of it is that a lot of providers just don't know how to help because, you would think that we're taught a lot about women's health. We are taught a lot about fertility and obstetrics, but in terms of optimizing health, dealing with fatigue, dealing with energy, libido, that's something that you sort of have to learn as a provider on your own. Like, I was interested and passionate about this, so I sought out how to educate myself on these things so I could help patients. But, we don't get a course on helping women with libido or fatigue, you'd think. I mean, there's like the very basic difference. Okay, what are their iron levels? What are, but we don't really get into the more nuanced sort of layers, deeper layers of it. So I think there's a couple things going on and why women don't really get the answers sometimes.
Did you guys have a course on HRT, or you just learned all of that on your own?
I did have a menopause course in residency, which is better than a lot of places, surprisingly. You would think that we'd get a lot on that, given that we're studying women's health. And I trained at exceptional places in New York City and big academic programs. But there was a big missing piece on how you can use that. This is not just reserved for women in menopause. This can be very useful for women in their 40s, in the perimenopausal phase. That was not really taught. And yeah, so I really didn't have a lot of training in that.
So interesting. It'll be really interesting. I mean, first of all, every doctor that I interview has the same kind of, story. And typically what I found is that everyone typically gets into, alternative functional integrative medicine based on kind of something that happened with their own health. Mm-hmm. But it's just so interesting. I wonder if or when the system is going to get a revamp. I was reading some literature stating that it takes about 20 years to be proven out in the science before even if it does get to bedside.
Right. Medicine moves at such a slow pace. And I think traditionally, we're always taught in medicine, like, you can't, everything has to be evidence-based with randomized controlled trials. But now when we're talking about precision medicine and longevity, everything is so individualized. Like, we can't wait for randomized controlled trials to always happen and result in, these are studies that take years and years. And medicine and science is evolving at such a rapid pace that randomized control studies can't keep up with it. So, it'll be interesting to see what happens. But sort of going back to what you had asked me, we had learned about menopause therapy as sort of like, if someone's having hot flashes. What wasn't really discussed was how important these hormones are for your brain and how they are important and necessary for sleep and mood. And so that's something that I'm so passionate about and want women to know, well, not just women and men, that, some of the reasons why women have difficulty sleeping or have new anxiety and mood and irritability in midlife without any other obvious external stress is because progesterone and estrogen are necessary for serotonin and GABAergic pathways in your brain, and they affect the level of neurotransmitters in your brain. They affect glucose uptake. And so that to me is like a whole fascinating world of, wow, because you're so interested in brain health yourself. Like, how did we not know how important these are for brain health?
Absolutely. I think that, I'm hoping that the misconceptions about like the safety of HRT, bioidentical, I'm hoping that those are going away. Although I will say my own mother, who lives in Ohio, called me the other day, and she is 53. And I've been, telling her, go to my clinic and start a hormone therapy. Yes. And she's like, but my doctors are saying that it might cause cancer. And I'm like, is that seriously still the conversation. I was mind blown.
I know. So I think it is changing. At least now, there's a lot more conversations about HRT. Celebrities are talking about their experiences in perimenopause. These conversations are so helpful. But, there was a whole generation of physicians that were traumatized by the WHI and were told, 20 years ago to take everyone off HRT. And now that generation of doctors are starting to retire. And that this, new set of generation are now understanding that it's okay. So things are going to change, but there's still so many providers who are scared to use it. And if they're not scared to use it, they'll only use it once someone is 50 plus. They won't use it earlier to help with symptoms. And sometimes, well, actually not sometimes, usually perimenopause has worse symptoms than actual menopause.
And correct me if I'm wrong, but isn't it better for long-term outcome, like reduction of cancer risk and cardiovascular risk, to actually start it earlier?
Yes.
Wasn't that one of the big flaws of the massive study, was that they started it too late?
Absolutely. So it was started on an average age of 62. By then, the average woman in the WHI was 62. By then, women do already have plaques formation in their vascular system. They already have like amyloid deposition in their brain and signs. Dr. Moscone, one of the leading brain scientists, showed that these changes for dementia and Alzheimer's start in a woman in their 40s. And so starting now, and cardiovascular disease. So the earlier you start it, the better. We want to ideally start it within 10 years of menopause, but ideally earlier, because these changes really start happening in your 40s. And interestingly enough, there's some research to support that bone loss is, we used to think bone loss really started exponentially happening in a woman's 50s. Now we think maybe even earlier in your mid-40s. So tackling those issues on and doing hormone therapy, the earlier the better, in my opinion, is what should be recommended.
Yeah, I agree and love that. I think the biggest thing that I just want to, shout from the rooftops, or even better, empower people like you and other doctors, is that it's not just like, I think that sometimes people think they relate hormone therapy, and I could be wrong, to, women want more libido and then hormone therapy. It's like, no, this is providing so many benefits to your brain, cancer risk, cardiovascular health, bone density, energy. It's almost just unfair to not explore that for women.
Totally. Here's a couple of statistics. Starting hormone therapy decreases your risk of cardiovascular disease by about 30%. 30%. That's not a single digit. That's a huge amount. Yeah. And by the way, like, some people think, a hot flash, like even when I was taught, a little hot flash sounds like a nuisance, annoying, but whatever. What people don't realize is the more hot flashes someone has and the more severe they are, the worse cardiovascular disease they are going to have. Because every time a woman, whether they're cycling, whether they have a period or not, or whether they're menopausal, every time a woman has a hot flash, her heart rate increases, her blood pressure increases. She's having these, think about if that's happening multiple times a day, you're increasing stress on your vasculature and your heart. So you're actually end up having more hypertension, more cardiovascular disease when you have your adrenaline, cortisol go up every time you have a hot flash. So when you're having that day after day, years after years, that's actually putting a huge stress on your cardiovascular health. It's not just a little hot flash.
Wow, that makes so much sense. And I'm so excited to put that into a clip and put that on social, because women need to know that.
Yeah. I mean, I remember thinking like, okay, hot flash sounds annoying, but whatever. But it's a real health implication.
Wow. Yeah, absolutely. Do you have any favorite forms of hormone therapy? Do you like creams, or there's so many different variations coming out now?
I generally tend to start with transdermal only because, and oral has a great, there's basically oral and transdermal. In terms of transdermal, I prefer patches or gels or spray. There's a spray too that I like. The issue with oral, the advantage is that it can lower total testosterone and can improve lipid markers by about, depends on what study you look at, but anywhere from like 15 to 20%. However, anything you take orally, hormonally, if it's estradiol, will lower your total testosterone. And I'm a big believer in supplementing testosterone for women as they age. So it's not my first choice. The other thing with oral, very minimal risk of a blood clot, but does exist. It's tiny. It's maybe somewhere in the lines of 3 to 5 per 10,000 women. It's less than a birth control pill. But anyway, oral tends to not be my first line just because I end up needing to give them more and more testosterone to compensate for that. So transdermal bypasses the liver metabolism, doesn't affect your testosterone level, and gets straight through the skin into your bloodstream. And you also have zero risk of DVT or clot with that. So I tend to favor transdermal formulations. And everything I do and would recommend for women is bioidentical, right? Because it's chemically made to look exactly like the hormones your ovaries have secreted. And that's why they tend to respond better to that than synthetic forms, because your brain recognizes it chemically.
Wonder, why do they even have synthetic forms?
I read this once because there was a reason. Because I think that you need... So bioidentical hormone therapy is about 1/3 the dose of ethanol of a birth control pill. So birth control pills are ethanol estradiol, and I think you cannot give someone that much high of bioidentical estrogen because it either it doesn't. I think it doesn't work effectively for birth control, but somehow it just because it doesn't work as well if you give them bioidentical high doses. They have negative side effects. And too much estrogen can be a thing too. More is not always better with women. It really depends on what their body's used to. So some women feel better at lower doses of bioidentical hormone therapy. Some women need more. It's really super individualized. But what I can say is that the birth control pill has its place, and in my opinion is not the best option for women in their 40s and anyone experiencing perimenopausal symptoms.
What do you think about birth control in general? Let's set aside, if you're using birth control simply for avoiding, conception.
Yeah.
Let's set that aside. If you do that, of course, to each their own. But are there there's a huge debate, obviously, on social media, right? Are there health implications? What are your thoughts on it?
I think it's so hard to be black and white about birth control because for some women it's freedom, it's reproductive, autonomy. Some women have conditions where they really cannot get pregnant because getting pregnant would be life-threatening. Women who have horrible, heavy periods, these women really benefit from the traditional birth control pill because when you compare the alternative, and not to even mention sort of reproductive rights in America, how important it is to have access. So I do think that it's really important for women to have access to birth control. I know this is debated. I personally don't think that it affects fertility, at least in the long term. It's possible that after a month, or it might take some women a little bit longer to have their normal cycles resume, maybe a couple of months. But I don't think it impacts negatively long-term health. I still don't love it for other reasons. I do think it can, it does decrease your total testosterone. It can result in, especially even young girls were using it for a long time, vaginal dryness, pain with intercourse. So there are ups and downs to it, but I think it has a role. I would say it's probably, given the, if all things being equal, I usually prefer an IUD just because it doesn't interfere with ovulation, and you can sort of do other things with an IUD that you can't with a birth control pill. But it really I think it so depends on the clinical context.
Yeah, that makes a lot of sense. Have you, I'm not really staying up to speed on the literature around birth control, but I have seen a few things that, there could potentially with long-term use, 10 years plus, be some sort of relationship with hypothyroidism. Have you seen anything around that?
You know what? I haven't. That's interesting. I would totally look into it, but I don't know, honestly, right offhand. I haven't looked at that research.
Yeah, it's interesting. I think we're just learning more and more all the time. So when it comes to an IUD, would you choose a copper IUD or would you choose the hormonal IUD?
Generally, I prefer the hormonal one in my group of patients because when I do bioidentical hormone therapy for women in their 30s and 40s, it doesn't provide birth control. So that's one thing they have to realize. And you can't use both at the same time. And women that are cycling or women that are 40 still can get pregnant. So it's something I have to consider. And a lot of these women, because of having really elevated levels of estrogen and progesterone, have very heavy periods. And so a copper IUD will not help with that. It might even make it worse. A copper IUD generally tends to make periods heavier. So for my patients, it's not usually the best option. And the progesterone-only IUD generally acts locally in the uterus, doesn't affect ovulation, doesn't really get, it might, maybe a little bit of it gets secreted in the bloodstream, but the majority of it is staying local in the uterus. And so that allows me to then give bioidentical hormone therapy in patches or pill or form while at the same time giving them birth control. So perimenopause is a little bit more nuanced with bioidentical hormone therapy because women can still get pregnant and you can't use sort of a pill and bioidentical hormone therapy at the same time. In menopause, it's a little bit more straightforward because you don't need to worry about pregnancy, so you can just give them bioidentical hormone therapy. So for me and my patient demographic, an IUD works really well for that.
And perimenopause, is that, would you say 40? I mean, I'm sure it can vary woman to woman, but is that roughly like 40 to 50?
Yes, I would say like late 30s, it really varies from woman to woman. But basically it's, our ovaries are the predominant source of estrogen, progesterone, and testosterone. And our follicles, the little eggs on our ovaries or the follicles, are secreting these hormones and regulating our cycles. But they age really starting in our late 30s. By the time we're 40, we've lost about 97% of our follicles. And so they're slowly starting. So what we know is that, menopause, the average age of menopause is 51. Menopause is defined as being 1 year without a period. But it's not like the night before your 50th birthday. You're like, and now I'm in menopause. Basically, estrogen and progesterone are decreasing but fluctuating a lot. And then in perimenopause, estrogen overall is going down, but you have these times where you have high estrogen and low progesterone. And you can have very strong clinical symptoms of this. And so, but basically the idea is overall things are trending downward, fluctuating, but still trending downward.
And can you just break down, so what is estrogen and progesterone doing in our bodies? Benefits, potential negative impacts?
So obviously they're coordinating your period, and that's what everyone thinks about them. We even call them reproductive hormones, but I even think we should question that terminology because they do so much more than reproductive health. Estrogen helps in bone remodeling, strengthening your bones. By the time a woman is menopausal, she will exponentially lose bone density, and about 50% of women will have an osteoporotic fracture if they're menopausal and not on hormone therapy. Estrogen is anti-inflammatory all over our body. Generally, it's just an anti-inflammatory hormone. So it helps glucose uptake in the brain cells. It helps antioxidant uptake in the brain cells. It helps increase serotonin levels. It helps cardiovascular health. So increases nitric oxide flow, decreases plaque formation. It is, in terms of sleep, melatonin is derived from serotonin, and estrogen's net effect in the brain is to increase serotonin. So it is helpful. It's important for sleep. So a lot of women in their 40s start saying, like, I'm waking up at 3 or 4 in the morning and I have no idea why. And it's because they have less melatonin, they have less serotonin, they have less estrogen. Mood and anxiety, serotonin. Again, SSRIs are meant to increase serotonin levels, that estrogen does the same thing. In our joints, frozen shoulder, estrogen is anti-inflammatory in the joints. Dry eyes, we have estrogen receptors in our eyes. Gingiva health, oral health, estrogen receptors. There's literally estrogen receptors everywhere. In our gut, we even have the estrobolome in our gut that a lot of this is new research, but we know that the gut is responsible for metabolizing estrogen and metabolizing it and then reabsorbing it into the gut. How that affects, how your gut microbiome affects overall estrogen levels is still a point of active research and investigation, and so interesting. I don't think we really clearly understand it, honestly. And then progesterone. Progesterone is important for bone remodeling as well, and sleep and anxiety. So progesterone increases GABA pathways and is involved in the GABAergic, which is an anti-anxiety pathway in our brain. So helps women fall asleep. So a lot of times if you're low in progesterone, you feel more anxious at bedtime, you have a hard time falling asleep, and acts as a sort of relaxation, basically, hormone as well. So it's really incredible that we have estrogen and progesterone receptors all throughout our body, from our head to our toes. Oh, not to mention like vaginal health and skin health. We have estrogen receptors, all over our skin.
So it's doing a lot more.
It's doing a lot more than just your period. Yeah.
Wow. Well, yes. So many amazing benefits.
Yeah.
What would you say? So if you were to have women test at a specific part of their cycle, when would you choose? Would you think if you were just going to do one lab, like would it be follicular phase? Because then I want to talk about what those ranges would look like.
Well, I would say, so it's interesting. Lab testing has been really not that useful up until now because, well, especially as the periods start to, especially as we have anovulatory cycles, meaning we're not ovulating every month, because then, so normally, traditionally, in a regular cycle, I would say probably looking at ovulation to see that there's sort of peak in estrogen, and then it drops right around ovulation time. And then day 21 progesterone in the luteal phase to see if that's peaking, because it may not be peaking if someone doesn't have enough progesterone. But what ends up happening as women age, starting in their late 30s, is they're not ovulating regularly, and so you don't have the traditional cycle pattern happening, and you end up getting you don't have progesterone. You sometimes can have really high levels of estrogen, estradiol. Sometimes your FSH is not reflective of, sometimes your FSH can lag, and then we have inhibin B. Like, everything is all over the place. I'm actually working with this cool company called Ellie Health that's developed technology to do, and this is still kind of controversial in my world, where saliva testing for sex hormones. Right now they have the capacity to test for cortisol at home, daily cortisol testing, because it would be really cool, like a CGM, to be able to monitor your cortisol trend patterns and then see if lifestyle interventions can help improve those cortisol levels. Because right now it's like, what can we show? Like, how do we really intervene in terms of improving stress and cortisol levels? So we have that technology developed. Sex hormones are next underway. Traditionally, most medical doctors are going to say that's not useful because we know that they're all over the place. But we don't know much because we haven't had the testing to be able to look at daily progesterone, estrogen levels and then trend it. Not only, and it also depends on the context. You're looking at days, weeks, monthly trends, and then yearly trends. Like, there's so much information to be gained out of being able to look at hormones from a daily, weekly. So basically, Ellie has the technology to gather this, put it into an app, formulate your own graph, and then be able to look at your trends from month to month, which I think is fascinating to see in which direction you're going, or if consistently you're showing that you don't have an elevated progesterone in mid-luteal phase, like day 21. So, I think this will provide a lot of information. But right now, as of now, it's really a clinical diagnosis. It's hard to, and it's tricky because women can often get dismissed because of that, where like they'll say like, I'm not feeling great, I'm not sleeping, I have no energy, can we send my labs? And then the labs all come back normal because the range is so normal. I mean, a woman in her 30s and 40s can have an estradiol of anywhere from 20 to like 900 or something. And that's considered normal because the range is so wide, but that's not reflecting the pattern or the big picture of what's happening. It's just a snapshot in time. So I think we need to collect a lot of data and actually be able to map out trends week to week, month to month, even compared, year. Being able to have a woman be able to track her own estrogen, progesterone every day would provide provide enormous amount of data.
Absolutely. Is Ellie doing cortisol, progesterone, and estrogen?
Right now, cortisol for sure, and the next plan is progesterone.
I love this. Yeah. That's amazing. I'm definitely going to look into that. Well, let's just say, before we get really deep into perimenopause, let's say a woman is in her 30s and tests estrogen levels in her follicular phase. What would you say is more of like, optimal range for that woman in her 30s? Let's say like their mid-30s. What would you say the range would be?
Oh my gosh, I think the ranges in follicular phase could be 30 to 200.
Do you have any thoughts on what the optimal range would be?
I don't know. And don't hold me. I don't know if there is an optimal range because I just don't. I think it really, do our higher levels more optimal. I'm not sure that we know that they are. I mean, they might be, but we just don't know.
So how do you determine, let's say I came in and I'm 33, and you looked at my levels, where would be maybe a concerning like cutoff either, let's say if we're looking at estrogen in the follicular phase, is there something that would give you pause and be like, okay, that's too high or too low? And then the same thing, maybe progesterone in the luteal phase.
Because these hormones range, I wouldn't look at estrogen and progesterone actually for this. I would look at follicle stimulating hormone because it should really never be above 25 in anyone who's premenopausal. So an FSH greater than 25 on 2 different occasions. And this is something that gets missed a lot because it can happen, you know, if women are going a couple months without a cycle and having irregular periods. But I have caught premature ovarian insufficiency or POI more often than I was surprised at how often I've caught it. So I think FSH is a better indicator because when your estrogen is consistently low, then your FSH is going to start to go up.
Got it. So anything over 25, not good. And you want to look at that in around ovulation or just
anytime
follicular?
Well,
anytime.
Actually, day 3. Day 3 of your cycle. So if your first cycle is if your first day of your period is day 1, we generally try to send labs around day 3. Yeah.
And so you mentioned FSH, and is it a fertility marker too? Like LH and FSH?
Yes, it is in the sense that if someone's FSH is above 25, that is not very promising for fertility because it's showing that basically what happens is we have a negative feedback loop from your ovaries to your hypothalamic axis. And so when you have enough estrogen, it sends a signal to the hypothalamus to shut down FSH. So generally your FSH should be low. But when you don't have enough estrogen, your FSH is getting secreted by the brain to try to tell your follicles, hey, we need more estrogen. So you see that FSH elevated.
That's really interesting. What lifestyle recommendations or supplements, is there anything, let's say you have that and you catch it early, then what could you do to kind of get that number back into range, if anything?
I honestly think that it really does require estrogen at that point. And I wouldn't recommend lifestyle for that particular such situation, just because anyone who has elevated FSHs at a young age really needs to be on estrogen to protect their bone health because that is such a serious, we don't like to think about, no one thinks about osteoporosis in their 20s or 30s, but the reality is you should be thinking about it because this is what women succumb to, or like falls and fractures. And the ideal time to prevent it is in your 20s, 30s, and 40s when you're cycling and you have estrogen in your favor. And then you can do lifestyle interventions like resistance training, walking with a weighted vest, or just walking, running, anything hard impact and building muscle is going to really help prevent that. It's much more difficult to reverse it's very difficult to reverse osteoporosis. And if a woman in menopause or a woman has an osteoporotic fracture, especially of her hip, she has anywhere from a 30 to 50% mortality rate of dying in the next 2 years. I mean, that's crazy. And that this is preventable. This is preventable. Not just, not every woman is a candidate for hormone therapy, and I want to acknowledge that too, although more are than they realize. But osteoporosis is prevented not just by estrogen, but also resistance training, testosterone, and building muscle. So, sorry, I forgot what your question was. But
no, it's okay. We were talking about what to do if your FSH levels are elevated.
That's right. In that situation, the recommendation is to give estrogen because it's so important for brain health and bone health. I really wouldn't recommend supplements in that indication. Now, there's other situations where I can clinically tell if someone has lower signs, like lower progesterone levels. So, for instance, if someone comes to me with a lot of luteal phase spotting, then I can recommend, and they don't want to do any kind of hormone therapy, chaste berry is a natural supplement. You probably are familiar with this, right? That mimics progesterone, so that can be really helpful. Ensuring that they have enough healthy fat and cholesterol intake. Sometimes I see young girls that are, really thin, that are not eating enough healthy fats and their cholesterol's on the lower end. And just by increasing healthy fats, because progesterone is derived from cholesterol. So you do need enough healthy fats to make these sex hormones. And so sometimes I had a patient who was just constantly spotting in the second phase of her period. And I was like, you know what? I couldn't figure out what was going on. And then I thought, you know what? Let's have you. So I was talking about her diet, everything, and she was eating she was sort of having a traditional standard American diet, not really eating a lot of healthy fats. And I said, I want you to eat more avocados. I want you to eat more olive oil. I want you to increase fat in your diet. And then really her cholesterol level came up a little and her spotting has just gone away.
I love that.
Yeah.
Okay, so what about LH? What role does that have? This is kind of bordering on like fertility conversation now, but what is LH? What is a measurement? What is it a measurement of?
We don't use LH other than maybe in polycystic ovarian syndrome, somewhat like in terms of the ratio. So the FSH to LA ratio tends to be reversed. Normally, you should have a higher FSH to LSH in non-PCOS patients, but we do sometimes see that the ratio gets reversed in PCOS. And that's really the only kind of time that a lot of physicians use this in clinical practice. I would say maybe fertility physicians use it more, but I personally don't use I don't have a clinical utilization for it quite yet because I'm not doing as much fertility stuff.
All right, super interesting. Just really diving into all things hormonal health. So I've seen on social media this going around about like yam cream. Have you seen this?
Oh, right. Because like some, hormones, bioidentical hormones are derived from yams. Yeah. I don't honestly think it can really help. It doesn't hurt. I mean, yams are good for you.
Yeah.
But in terms of like applying it to skin and stuff for like hormone health, there's other things I would recommend more potentially chasteberry and, there's other supplements I like, but I don't think yam is honestly going to provide enough clinical benefit.
Yeah, that makes sense. Well, thank you, because that seems to be like trending right now.
Yeah, okay. I don't even know what's trending, so I'm glad you're telling me so I can go and look up these things because I'm not on TikTok, so I don't know what's trending, so that's good to know.
Yeah, I mean, my whole feed is like health stuff, so, just interesting things are coming across all the time.
Yeah.
And what about, have you seen some of this new research on rapamycin and, potentially pushing back menopause and being good for ovarian health? What are your thoughts on that?
Yeah, I think it's really interesting. I mean, rapamycin's been around for a bit in longevity circles. A lot of my colleagues in longevity take it and really recommend it. I think it's really interesting, but I think it's still, we don't have large population studies on how to use it for ovarian health. Traditionally rapamycin is an immunosuppressive drug for basically organ transplant recipients in order. So it is, it's going to suppress your immunity. So you have to balance, it has to be in small enough doses that you're not at the same time suppressing the immune system enough that you could create another problem of like a new cancer emerging or a new infection emerging at the same time. So I'm not at the point yet where I'm recommending it to patients or prescribing it, but I think it's fascinating. I think potentially we're a couple of years away from that, but I think it's incredibly interesting because I do think there's definitely for sure a lot of autoimmune. A lot of these women who we do find premature ovarian insufficiency have other immune issues going on. They tend to go hand in hand. So a lot of women who go through perimenopause or menopause earlier also have thyroid issues, have Hashimoto's. So there's definitely a connection. So it's interesting. I think it's cool. I am reading about it. I haven't yet. I'm not recommending it to patients quite yet. I think we're a couple of years away, but I think it's potentially promising.
Yeah, that's great. I was going to ask about the mechanism of action. You think why it could be beneficial, but maybe, it seems like your line of thought is the women that are having the premature aging of the ovaries also have an that makes a lot of sense. Yeah. So you're, by kind of tampering down the immune system a bit, it's then, I'm so shocked. I was, talking about this earlier. I'm new to LA. I'm meeting so many women. And before I was just like in my clinic working. And of course we saw people with chronic conditions all the time because that's why they were there. But just in general, speaking to women, I literally, and I'm not being hyperbolic when I say this, I don't think I've met a single woman in the past few months that doesn't have some condition, either PCOS, endometriosis, or an autoimmune condition of some sort. I'm mind blown. These are young, in 30 to 40 years old, seemingly healthy, looks healthy. They work out. It just...
And by the way, these are underdiagnosed, these conditions.
I'm shocked.
Whatever we think, however, we know that PCOS gets underdiagnosed. There's way more patients with PCOS than we realize. Endometriosis gets undiagnosed all the time. So probably more women than we even realize have it.
It's so sad. And I'm just beside myself about it.
And it seems to be increasing. But I think, honestly, especially with PCOS, for sure lifestyle is a huge part of PCOS.
Yeah.
I think there's a lot of autoimmune stuff going on in endo as well, in endometriosis. It's a very high inflammatory state. It tends to go along with women who have IBS and fibromyalgia, and just tend to be very sort of have just a lot of inflammation. So there's something, it's complex. We just don't understand it. But again, we haven't had research dollars allocated to women's health, because up until 20 years ago, the idea was that, women are cycling, it makes them too complex, so we can't apply these, we can't include them in clinical trials. Mm-hmm. I mean, it's so crazy. And so, yes, that's exactly why we need to study women, because we have these hormonal fluctuations that are impacting health so much. I mean, things are changing. The Biden administration just last year announced the $100 million to go towards women's health. Something like 90, I want to say it's of all research dollars, I have to look back at the actual numbers, but it's such a small amount. Maybe it's single digits of what research funds are allocated towards women's health. And within that, the vast majority is pregnancy and fertility. There's very little on actually hormone health and PCOS, endometriosis. I mean, we're talking 0.02% of research funds are dedicated to PCOS and endometriosis. I don't know if it's that exact number, but you get the idea. It's It's literally single digits.
Well, I mean, I feel like there's going to have to be a major reckoning, because women are the ones creating the men. And when you have all of these chronic conditions, endometriosis, PCOS, we know that they highly impact your fertility. So
totally.
I mean, we need more information on this. It's totally insane.
It's insane. And that we expect women to be such highly functioning. Women, there's so much demand on women. They're the primary caretakers of everyone, their kids. Women are doing more, accomplishing more, having careers, taking care of households, running households. And yet their health is not being prioritized, and it's not right, But I think things are changing. These conversations, bringing awareness, is changing. A lot of celebrities talking about their experience through perimenopause or endometriosis or PCOS is so helpful to normalize this, so that women don't feel alone. But really what we need is research to understand it better. I mean, I know there's so many women with autoimmune issues, and they, I think in that respect, functional medicine physicians have been way ahead of the game, because we just don't understand autoimmune issues in women, and they get dismissed all the time, and yet they have very similar patterns, So there's something there. We just don't fully understand it. I think functional medicine physicians understand it way better than we do, honestly.
Yeah, one of our primary providers at Live, she, is functionally medicine trained. She came from Cleveland Clinic Center for Functional Medicine. And, obviously, your patient base becomes what you're really good at.
Yeah.
And we have so many patients that, truthfully, she helps to put into remission for things like Kashi and these different autoimmune conditions. But it is so complex. It's not just one thing.
Right.
And when I'm speaking to these women, obviously, I have a platform. So, when I go to different kind of communities here, a lot of times people ask me questions and tell me, what they kind of have been diagnosed with. And I have zero chronic conditions. I mean, I'm in the, I think it's only 6% of the world is metabolically healthy at this point based on these, 5 criteria. I'm obviously that. I have no autoimmune conditions. But I've done so much over such a long time that obviously we know it works, but that's not a reasonable thing to tell someone changing your entire life. I mean, the carpet we have in this room is organic right now. It's
right. But we know that lifestyle definitely impacts these. I mean, metabolic disease, basically thousands of years ago, we just didn't evolve fast enough to be able to metabolize and tolerate all the toxins that we were exposed to in the span of a couple hundred years. So we went from eating, so organic, grass-fed, whatever, thing, product,
which was normal,
which is called
food.
Real food with with good soil, with nutrient dense soil, to then industrial farming and the Industrial Revolution and grocery stores and all of these crazy synthetic chemicals that literally our bodies have no idea how to metabolize or take, and they must have long-term effects on our health. It can be overwhelming for women to be like, where do I start with this, especially when thinking about fertility. But I think simple ways can go a long way, in terms of just trying to use less plastic. I mean, that's the first thing. I mean, it's hard, right? I mean, things you wear, but in your kitchen, like where you're cooking, that's where you can get a lot of bang for your buck with that in terms of trying to transition to like wood and glass and materials that have been around forever as opposed to, chemical and synthetic plastic. So, I mean, I'm preaching to the choir, basically. But you're right. It's hard. It's hard. And lifestyle changes aren't easy, but lifestyle works when done consistently, and it does take time. But consistency is the most important thing. That's the other thing I try to tell patients. When they're like, haven't been working out, what's the point? You don't need to work out. Yes, ideally an hour a day is great, but that's a luxury. Not everyone can do that. And I tell women a lot, like 10 minutes a day when done, 10 to 15 minutes a day when done consistently is so beneficial for your health. Now that we're sort of talking about metabolic disease and stuff, because so much of our, population has prediabetes or insulin resistance, including myself. So I'm really interested in this topic. But, I forget the exact study. I'd have to look it up. But basically, when people, the ideal sort of recommendations for lifestyle is 150 minutes a week of moderate to vigorous exercise. But you gain much more benefit those first sort of the initial sort of few hours. The benefits are always there, more exercise the better, but it kind of plateaus a little bit after you've reached that amount. So for women that are overwhelmed with that, I'm like, you'll gain so much benefit in just doing a little bit of exercise. Yeah. Like enormous. And it's not just helping one area. It's helping your cognitive function. It's helping your metabolic health, your cardiovascular health, your bone health, your mental health. Like it's infecting all systems of your body. So little things go a long way when done consistently.
Yeah, absolutely. Yeah, and it's hard, but it's like, I mean, you can't not do it. Unfortunately, like you can't not exercise. You can't not walk, you can't not get your steps in because unfortunately, I mean, there's always going to be outliers, right? But you're eventually going to run into some major issues. And we know that chronic disease develops over the course of 10 years, right? Yes. Cancer. I interviewed, Dr. Keneally and some of these top experts. This is developing over the course of like a decade, not like overnight in most cases. Yes. So it's like doing those consistent habits, even just, getting morning sunlight or, doing, I think sauna should really be like, it has to almost be a requirement now because we do, like you mentioned, we have such a high toxic burden that our bodies weren't made to handle.
They can't handle the toxic burden. Right, so that's right.
You can sweat via exercise, too, if you can afford a sauna or can't, go to get one. But, do vigorous exercise and sweat because it's a detoxification mechanism. If you're not going to the restroom regularly and once every 3 days or 2 days is not normal, that's a detox mechanism, right?
Totally. So, and even cold plunging. You don't have to have a cold plunge like tub. You can do it in your shower. Mm-hmm. I was actually doing research for Ellie in terms of how we can impact cortisol levels. And I was really impressed by the research on, this is, I know, so old news, but I have to say, I was like, I don't know. I mean, I'm sure probably your cortisol levels spike at some point when you initially dive in. And then when I started looking at the research, I was like, wow, this is really impressive. And that you can do it in your own home. It's easy to do it in your shower, even if you don't get it, even if it's not the ideal temperature, it's still, even going colder is always going to be beneficial, even for 30 seconds at the end of your shower, a minute or whatever.
Totally. Well, I mean, there's a lot of research on the metabolic benefits also, just improving metabolic health, which we're going to be doing a cold plunge later today, which I'm very excited about.
I was like, you're holding me to it, Kayla. I was like, can I just preach the benefits of it and then not actually do it?
Oh, no. I checked it this morning.
Oh, my God.
Everything's all set. It's
all right, let's do it. Let's do it.
I'm excited about that. I love it. I mean, the first times I ever did it, of course, I was like, whoa, this is pretty intense, but it feels amazing. It just, your dopamine, serotonin, everything is elevated. I mean, I feel like, it helps with just metabolic health. So,
well, anything that lowers cortisol is going to help your metabolic health, you know? So yeah, that makes sense.
Well, there's research on it being able to, convert the more white fat, which is the like blubbery, like more toxic fat, into brown beige fat, which is more metabolically active. It's healthier when we're born as babies. We have a lot of this brown fat, right? But we lose a lot of it as we age, but it's a lot healthier. So
interesting.
That's also another great benefit.
Yeah.
So excited to do it today.
Yeah, I'm excited.
All right. Well, actually, on that point, so I do my cold plunging in the first half of my cycle.
Okay.
Instead of doing it because I want my progesterone to rise in the second half. I don't want to tamper it down with a lot of hormetic stressors. Do you agree with that? Yeah.
Usually we say the follicular phase when women are feeling better, right after their cycle is the time to go hard on the exercise. It really varies from woman to woman, but I would say, that would be the ideal time. You tend to be a little bit more, I tend to be kind with yourself, especially right before your period, luteal phase, when most women are having big hormonal fluctuations, can have migraines, can have mood issues. And so for that, not the ideal time to go all out sometimes, but it really depends on the person. But yeah, that makes sense what you're doing.
Yeah, and it seems to work really well too. I kind of am somewhat putting together my exercise routine and, cold plunging and different hormetic stressors along my actual cycle, which I think, women should just, if you don't already know about your cycle, I think it's super powerful and helpful just to learn it. I sync Oura Ring with an app called Natural Cycles. It's so informative.
Yes.
Shows you where you're at, average length of cycle. I use that for birth control at this point. Yeah. So excited because sometime in September, October time, we're going to be switching it from the trying not to get pregnant stage to the trying to get pregnant stage, which I'm so excited for.
That is exciting.
I know. I can't wait. I want to have a lot of kids.
Yes, I know. I heard you say that on your episode with Molly Maloof, which I loved. Yeah, that's exciting. That's awesome.
Yeah.
I'm curious to know how that will influence your approach to everything, because it's definitely it can be,
Yeah, a lot of people on the internet are asking that too. What's going to happen to this routine once you have kids? And I mean, look, we're going to just find out.
You're going to do it, yeah.
Yeah, I'm going to try to. And another thing that I'm going to do that's going to be super cool is I'm going to do labs every 2 weeks while I'm pregnant. I'm not going to do it with all my pregnancies.
Oh, cool.
But because I feel like we don't have this information.
No, we don't have this information.
Yeah.
No, this is amazing. That's so cool that you're doing that. I love that. Yeah. It's so fascinating. Yeah, there's so much from labs that we need to learn in terms of especially sex hormones. So that's awesome.
I'm excited. Yeah, I'm going to do blood labs. I'm going to do NED levels. I'm going to do biological age. I'm going to do the whole 9 yards because we know some things. We know biological age increases make sense, right? Yeah. You're literally creating a human being. It's so amazing. But there's just a lot of stuff we don't know.
Yeah,
so
totally.
We'll see what happens.
What's your favorite test for biological age?
The True Age test. Yeah, they actually just rolled out one too that is basically it's testing all the ages of the organs. So, and I've done them all, and it's so interesting because there's variation for sure. So I'm excited to see. I think the key is pick one and then stick with that and watch what your results are, right? Because there's the glycan age, there's the true age, there's a lot of different I think function. They just use biomarkers to kind of assimilate what they think the biological age is. So
I'm looking into True Diagnostics to offer that in our practice and do that. Yeah,
I'm good friends with them.
Cool.
Yeah, I can put you on a message. But yeah, it's they have a lot of research going into it, and they keep really wanting to be ahead of the curve. So I think it's great. But as you and I were talking about before, it's exciting to have all these biological age tests, but it's not you can't really miss the forest through the trees.
Right.
If you have major rocks that I would say you need to address,
absolutely
a horrible gut health, or if you have a toxic burden that's super high. So, I mean, on a yearly basis, I do the gut test, I do, the total toxic burden. Yeah. If you have any, if you need to add more muscle, if you have bone density issues, we have to address these things first.
You have to get the basics right. You have to get the foundation right, and then you can add on everything. I agree.
Yeah, because for me, it's almost anything that you do, I suppose, No, not necessarily though. Like let's just say caloric restriction, for example, okay? That will probably reduce your biological age. That's one of the things that we know. I think we know for sure rapamycin has been proven out in a lot of trials for life extension in the models that they've done it in. And then we know caloric restriction.
Yeah.
So let's say you start calorically restricting and you see improvements in that. But what if then your testosterone tanks?
Right.
Or what if then you're losing muscle mass
or whatever.
Or your hormones are tanking. So I love the test. I think it's really fun that we're living in a time where people are like rejuvenating as a sport. I think that's amazing. But I, just also think we need a whole picture. And for me, I would start with a gut test.
And I agree.
That's what I would start with.
I think gut's so important. I mean, we know how important it is for mood and serotonin. And no, I agree. You start that. In fact, even when people ask me like, what should I do about vaginal health? I usually am like, focus on your gut. I don't think, I don't think that you need separate vaginal. Personally, I don't believe that there's data to support that you need separate vaginal probiotics in addition to gut probiotics. I think whatever benefits your gut is going to help benefit everything else.
Yeah, absolutely. So I had like the most perfect gut test I've ever seen. It was like zeros across the board and like a 1 on dysbiosis or 2 on dysbiosis. But then I did antibiotics, so I got an explant. I don't know if you even know that, but a long time ago I got breast implants. I got them out. Anyways, I had to take antibiotics. And I was like, okay, this is exciting. So I'm going to figure out what this just did to my gut.
Yeah.
Wrecked the gut.
You're kidding.
Wrecked
so
the gut.
interesting.
I just got my new results back. Inflammation is still 0, but dysbiosis has increased by like 5 points. And some issues with like digestion also. But I mean, it's great because I know exactly what to do to fix that. But it's amazing because, I mean, I had to take the antibiotics because I had the surgery. I didn't have,
and in the big picture, that was actually more important in your long-term health to do. Right. And you knew what to do to compensate for the gut thing.
Exactly. But it's amazing for people that are on antibiotics all the time. Definitely not saying that you shouldn't go on antibiotics if you need them.
Right.
But I have like, in my clinic, our provider calls it the big gun. Like that's like the most you can do.
Yeah.
So I'm on like the biggest gun probiotic right now and just doing so much. But it's important to know that there are things that can compromise your gut. That's why it's also important to keep testing,
Well, and like for GYN and women's health specifically, whenever someone has, a vaginitis or needs some kind of antibiotic, I'm always like, let's use the suppository first. Like, don't just jump to the oral diflucan, antifungal, because I'm like, that's going to mess with your gut. Let's try to do topical suppositories first as much as we can. If that doesn't work, then we'll consider the oral. But some of the most common medications that I used to prescribe would be oral, metronidazole for bacterial vaginosis or oral diflucan. Now I've stopped doing that orally unless it really topical is not, or a suppository is not working. But I think whenever you can opt to try medicine that's not oral, you should.
Yeah, no, absolutely. So that was a fun experiment, and I literally just got the gut test results back. So,
well, and the good thing that people should know is that you can really change your gut pretty quickly, like within some say a few days to a few weeks. So of consistently like eating well and eating, the right things.
Yeah, and the gut's so complicated too. I mean, it's like, I didn't have any pathogens or candida or viruses or anything like that. But if I did, that's a different protocol. That's why it's so important to really work with someone that knows what they're doing with gut health optimization. And that's why, despite many brands reaching out and wanting to do brand deals for probiotics, I've never done one.
Same.
Because I think that there's not a one-size-all-fits probiotic. And it's going to be like very targeted. So I'm excited too. But anyways,
that's cool.
What we knew about antibiotics proved out to be correct.
So interesting to see that actually on paper, though.
Yeah, play out. Exactly. No, I agree. So women that get yeast infections and UTIs, I'm sure there's different reasons, but people that get these chronically, why?
So a couple reasons. It depends. Let's just say let's say younger women for now. A lot of times, so there's more resistant because of the chronic use of antifungals. There's more resistant. So the 90% of yeast species are Candida albicans. We're actually seeing in more resurgence of resistance. So that's Tropicalis and Galbrata species, which the typical diflucan or monostat's not going to treat. And so if someone's experiencing that, one of the things that they can do is actually specify, because most testing will just say yes, positive or negative. It doesn't actually specify the species. If you're someone who's finding that you're not getting better, you need to ask your doctor to send a speciation test, which is not done automatically in that case, because there's different protocols and some medications actually have to be compounded for that. Although I like my statin ointment, it usually takes care of resistant strains. So first of all, there's more resistant strains happening, which is one reason, and the traditional first-line meds are not cutting it. Estrogen hormones are important in your immune health. So some women who are very sensitive to their immune system and hormones end up having more yeast infections during ovulation time. That's right when that estrogen peaks and then drops precipitously. Often women can say, like, around ovulation time, I always get yeast infections. So that's another reason. And then diet, sort of our pre-diabetic, insulin resistance of sort of having elevated sugar in our system feeds yeast. And so that we know that type 2 diabetics get way more yeast infections, but it's a spectrum, right? So the more sugar and the more processed carbs that you're eating, potentially you could have more yeast infections.
Great point. Is there a link if you have like candida in the gut to having vaginal candida or no?
I think so, because the proximity of the perineum and just the anatomy of it, is the area so tightly close together of, the perineum of a woman is like 2.5 to 3 centimeters or something. So it's just by proximity, your gut is going to affect your vaginal health.
Very important for people to hear that. Okay, and what about UTIs? Is it a myth that you should go pee after having sex?
No, it's not a myth. I mean, look, some data is mixed, but overall, we know that peeing can kind of flush out any kind of bacteria that can linger around the urethra. So it's sort of like, running a faucet a little bit like after. I mean, it's certainly not going to hurt. If anything, it might help. I would say do it. In women that are perimenopausal or postpartum, so any type of I've been back. I know I'm like back to the hormones, but estrogen, we have receptors in the urethra, vaginal tissues, and any low estrogen state will put someone at risk of having recurrent UTIs. So that could be not even menopause. That could be postpartum. So when a woman is postpartum after giving birth and breastfeeding, prolactin, which helps stimulate breast milk, suppresses estrogen. So you're in a very low estrogen state. So these women often can get UTIs and can benefit from vaginal estrogen, perimenopausal women, and for sure menopausal women. So that's one reason why recurrent UTIs can happen. And that's usually sort of the main, in terms of women's health, the main reason why.
So what would be the fix there? Would they be thinking about an estrogen cream?
Vaginal estrogen, yeah. So vaginal estrogen works really well in preventing urinary tract infections because as opposed to other types of topical things, it gets absorbed into the skin deeper and actually alters the pH. Normally, the vaginal environment is acidic. We want to keep it that way. It keeps the vaginal microbiome healthy by keeping it acidic. And when we lose estrogen, basically the bacteria lose their glucose, their source of glucose, and the cells become smaller, lose water, the pH becomes more basic, and women are more susceptible to infections. So vaginal estrogen can be a game changer for women that have recurrent UTIs in perimenopause, menopause, or painful intercourse. It's sort of like a couple of reasons too. As you lose estrogen, your skin is becoming thinner. You don't have as much elasticity, so you can get micro tears. And estrogen helps prevent all of that. And anyone's a candidate for this. Breast cancer survivors, like anyone can take vaginal estrogen. It should be really, in my opinion, not prescription.
Why do people think that you should drink cranberry juice?
There is, so it's generally not like the typical, what is that brand of cranberry juice that has all the sugar? Not that one, but actually, yeah, like the Ocean Spray or whatever. We're not talking that cranberry juice. We're talking like pure tart. Yeah, pure tart. There is data that supports that it helps prevent E. coli from attaching to the transitional cells in the bladder. So that can be helpful, but it has to be the really tart one that's hard sometimes to take. But yeah, it can help.
Good.
Yeah, it can definitely help.
Well, hopefully all that information is helpful. That's such a bummer if you're dealing with that all the time.
I think the other thing, too, is like if women tend to feel like they're not getting answers, there's a whole urologist and there's a whole set of physicians that do just vulvar health and sexual medicine. A lot of them are urologists, but not all of them. And so if you're someone who's getting recurrent UTIs despite, using these simple measures, or getting recurrent yeast infections despite getting speciations and making sure it's not a resistant yeast, you should specifically look for vulvar sexual medicine doctors who exist that literally specialize in the vulvar issues and like local vaginal issues. So there's doctors who actually just do that.
That's super helpful. We're going to talk a little bit about the future of screenings. So we know that for cervical cancer for women, the standard is pap smears, right?
Yep.
When do you start getting those, and how frequently are they?
Yes. So we start at 21, and it depends on the context of usually let's say your average person with no high risk HPV, 3 to 5 years in general. I generally do every 2 to 3 years in my practice. That's just me. But standard of care is starting at 21 and assuming a normal PAP 3 to 5 years. If someone ends up having high risk HPV, that changes things. And depending on their age, generally we leave it alone if they're under 30. If they're above 30, we do colposcopies and biopsies, because women under 30 have great immune systems. If they're healthy, not smoking, and doing everything right, they will most likely clear it, or at least, their immune system will keep it harbored at bay. And we don't need to intervene. Most cases, it goes away on its own. So for younger girls, we can sort of watch and wait. As we get older, above 30, and then above, in our 50s, we tend to intervene a little bit more because it's harder to clear.
And what do you think the future of that looks like?
Yeah, so the FDA just approved self-screening. So basically patients would be able to take a swab of themselves and then send it in under the supervision of a physician, of course. But that would be great to be able to make it more accessible to women who can't get to the GYN office or homebound or whatever, so don't have good access to care. So it's going to become more accessible, and the future is going to be self-screening.
That's great. I love just the rise in these at-home wearables and tech and tests. It's just, it's amazing. Yeah. I love it all.
The more we can do in terms of not requiring patients to jump through the hurdles of the healthcare system, the better. Yeah.
Yeah, absolutely. Going back to perimenopause.
Yeah.
So we talked a lot about kind of HRT and some of the benefits, but do you have any other thoughts on, reasons why it's so important for women to be considering this at least?
I think that women in their 40s, it's sort of a perfect storm. You have, increasing demands from children, increasing career demands, and then so many providers just aren't comfortable prescribing HRT. And so it's very hard, if you even find the time to get to the doctor's office, more likely than not, they're going to recommend for you to go on a birth control pill, which is not my favorite option for someone in perimenopause. And so I think a lot of women just kind of grin and bear these symptoms and deal with it. But it's so important to prioritize our health. It's not selfish. It's, we as give so much to those around us that I'm a big believer, and I'm so passionate about women investing in their own care and themselves, because you can't take care of other people. And when you feel good mentally, emotionally, it has a ripple effect on everyone else. If you don't feel good, we put so much emphasis on how we look on the outside, but feeling good on the inside is so important. Having mental resilience and, waking up with energy. How can you take care of everything around you if you don't feel good on the inside? So for me, I'm always stressing. I'm here for the 40-year-old mom who has kids, who's working, who's not sleeping, fatigued, and is just constantly giving. And so I think we need to really remind women to take care of themselves.
I mean, absolutely. I always say health is the foundation of greatness in your life, essentially.
Absolutely.
It's when you don't have energy and you don't feel well, you can't do all of the things that you want to do. You can't show up for the people you love. You don't dream as big. You don't think as clearly. So
no, it's not selfish. It's giving to others around you. Being able to feel good and will have positive effects on those around you, for sure.
Yeah, absolutely. How do we segue into relationships?
Well, I think that, in terms of affecting feeling good and feeling rested and mentally resilient is so important because it does affect those around you. And, a lot of women feel, the other part of the most common, issues that come up in my office are not sleeping, more irritability, weight gain, a lack of libido. I like the classic thing is like, I love my husband, but I have no libido. And we know that for libido, women, for women, it's a little bit more complex. We have this biopsychosocial model, which basically the easiest way to say it is that there's a couple of things. One is that stress and being in fight or flight or elevated cortisol levels definitely impacts women. Women, we have the ultimate multitaskers, which is great in some sense. Like if you want to get something done, give it to a mom, but that, can sometimes backfire on us because we don't know how to turn it off. Like women, they have like 100 tabs open in their brain. They're constantly multitasking. I don't think we really were meant to really multitask. We were meant to focus on one thing at a time. And so if you're and then not to mention our modern society is just set up to, constant go, chronic stress, never sort of taking a moment. And so when women are in fight or flight mode, their brain sort of, if you think about it from an evolutionary perspective, it makes sense. It basically kind of shuts down, underregulates that area of like arousal and sort of sexual sort of curiosity because it's like, this is not a good time to procreate. Let's not address that right now. At the same time, so stress impacts it, sort of social, women are doing more and more in the household, but still having the same household responsibilities. So they're accomplishing more outside of the house, but still having the same amount of work in the household. So unequal distribution of childcare or home duties can impact that. Long-term relationships, there's research that shows that women that have been in a relationship for more than 2 years tend to not have that spontaneous desire anymore. So I have a good friend who was like, I always was telling my husband, it's not me, it's you. And then she's like, and now I'm like, no, it's you actually. Because women tend to have more responsive desire when they're in long-term relationships. So while they may not have that initiating desire, they respond to sexual stimuli once it started, but they tend to not be the initiators if they've been, and of course, I'm not generalizing, this is a generalization, but this is what research shows is that in long-term relationships, women just don't have that spontaneity as much. And then at the same time, testosterone is decreasing. So testosterone peaks really in women's in their 20s and 30s, starts to decline in the late 30s, early 40s, and really is pretty very, very low in a woman in their 50s. This is important for, vitality, energy, and libido. And so I think it's just like everything else, I think it's also testosterone is important for body composition, muscle, bone density. So there's sort of all these factors happening that contribute to this. But relationships are so important for your long-term health, positive relationships. And you're spending all this time with your partner or spouse, like, I want women to thrive. I think women's female sexual health has often just been ignored. There's something like 35 versions of Viagra out there, but, and that's not the only piece. Like it is a little bit more complex, but there is a biological component in the brain that gets affected, and the hormones play a role as well as to why women have less libido as they age. Estrogen also has a role in libido. And so, I think it's so important to address sexual health because this is your quality of life, and we know that, oxytocin secretion, bonding between couples is so important for long-term health. So I address this, in my practice, and it's so crazy to me that like everyone knows Viagra exists. No one knows that we have 2 FDA-approved medications for low libido. One is Addy, which is a medication that works in the brain that you take every day and is great, and I'm a big fan of it. There's also a peptide called Vyleesi, which is bromolanotide, and that's an injectable peptide that's been shown it works in the melanocortin part of the brain. But women's sexual health is important. They deserve to thrive, and so I think, we have to, it's a multifaceted. That's why I also loved, and I loved listening to your episode with Dr. Maloof, because I think that what she's doing with Adamo is really interesting because often we just don't learn about how to have a healthy sexual relationship. We know no one teaches you this. And so a lot of women sort of think this is just normal but it can really impact and cause distress in a relationship. Like I've seen that in my practice. It can cause resentment. And I think it's so interesting when I've given Addyi to patients, they'll come back and be like, wow, I don't even remember. I forgot what it was like to have sexual thoughts. It was so cool. It's so cool to feel that again.
Wow.
So I think a lot of women want to have like thriving sexual lives. And I think it's something that we should address.
Yeah, I mean, I think that's super important. I always joke around with my husband that I need like an oxytocin hit and have to like hold him.
Yeah. And that's the other thing is like in our fast-paced society, especially, it'll be interesting. I want to pick Dr. Maloof's brain on how this works when, young kids, they're a great blessing, but it can be cause an enormous stress on a relationship too. And, I'm curious to know how, the biggest women impacted are the ones with young kids, for sure. I see that. I have in my practice women that are menopausal having great sex lives, but definitely in women in their 30s and 40s, it can be like the stress, the mental load on moms can be a lot, and it's a journey, right? It's not going to be a quick fix, but no one's teaching us like how to address this. And so anyway, that's important for long-term health. Your relationship, who you're with every day. Surrounding yourself by people who bring up your positive energy, dopamine, not, sort of creating boundaries and limiting toxic relationships or people that bring negative energy, not just sexual relationships and partnerships, but also just friendships. Any relationship is going to impact your health long term.
Absolutely. No, I mean, I agree. I have a pretty high threshold these days of just, levels of toxicity that I'm willing to deal with. And it's just not high at all, because it's like, you can be friendly and kind to everybody, but it doesn't mean that you have to keep them like super close if they're causing stress in your life. I just think that's not a great way to go. Yeah. And I know that that's easier said than done. I definitely know that.
It's definitely easier said than done, especially for people who tend to be caregivers and people pleasers. It's really hard.
Yeah. No, I agree. Well, I mean, this has been amazing. Thank you so much for being here.
Yeah, thank you. This was so great. And I love your podcast. I love everything you're doing. And I'm excited to increase to do more longevity in my practice. There's just so many cool things happening in this arena.
I know. It is such a fun, fast-paced, like evolving industry, and it's amazing that you're really just like leaning into that and wanting to help women. So thank you for that.
Yeah, my pleasure. Thank you for having me, Kayla.
Of course.
This podcast is for informational purposes only, and views expressed on this podcast are not medical advice. This podcast, including Kayla Barnes, does not accept responsibility for any possible adverse effects from the use of the information contained herein. Opinions of their guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about guest qualifications or credibility. Individuals on this podcast may have a direct or indirect financial interest in products or services referred to herein. If you think you have a medical issue, consult a licensed physician.